Everyone, and welcome to the Preparing for Zika in Virginia webinar. We're happy to have you all here. My name is Ashley Ewing. I'm going to open up the webinar. Just a few housekeeping items. Please make sure you keep all phones on mute and avoid placing your line on hold. We will take questions at the very end of this webinar, so please hold all questions until the end. You can ask questions at the very end of the webinar by using the Raise Your Hand feature located on the left-hand side of your GoToWebinar control panel. Right now, I'll turn it over to Dr. Tom Ryan, who will introduce our speakers for this afternoon's webinar. Dr. Ryan?
Thank you, Ashley. This is Dr. Tom Ryan, Senior Medical Advisor for VHHA. Welcome this afternoon. Zika virus is one of the most critical infectious agents now impacting people in the Western world. Discovered initially in the Zika forest of Uganda in 1947, it has produced intermittent outbreaks across the Pacific Islands and into South and Central America. We in the continental United States are now at risk for this mosquito-borne virus as it makes its way up into North America. The impact on infected people, most particularly pregnant women and their babies, is significant and alarming. We have known it was coming, and now it is here. This webinar is meant to increase your awareness of the Zika virus disease, its infectious characteristics, and its potential impact on our population. Joining the discussion this afternoon is Dr. Laurie Forlano and Mr. Reece. Dr. Laurie Forlano is the Director of the Office of Epidemiology at the Virginia Department of Health and also serves as the State Epidemiologist. She's a graduate of the Philadelphia College of Osteopathic Medicine and received her Master's of Public Health degree from the University of Massachusetts. She is board certified in preventative medicine and in public health. Mr. Reece serves as the technical advisor for the Hospital Preparedness Program for the Virginia Hospital and Healthcare Association. Prior to this role, he has served as a regional hospital preparedness coordinator for the near Southwest region of Virginia. He has been Vice President of Roanoke Memorial Hospital, CEO of Giles Memorial Hospital in Harrisburg, Virginia, and has served as Chair of the State Trauma System Oversight and Management Committee. He has also received a gubernatorial appointment in the past as a member of the Virginia EMS Advisory Board. Mr. Reece received his Master's degree of Health Administration from the Medical College of Virginia, VCU. Dr. Forlano, will you begin, please?
Hi, thank you. Ashley, just want to make sure you can hear me all right?
We can hear you just fine.
Excellent. Okay. Good afternoon, everyone. Thanks for joining us today, and thank you for giving me the opportunity to speak to you about Zika virus disease and what it means for Virginia. On the first slide, let me see if I can, hold on one second. There we go. First slide, you'll see the list of topics I hope to cover today in the brief time we have. I could probably talk for several hours about many of them, including the basics of Zika virus, diagnostics, epidemiology, and some of the newer clinical guidance that's been released recently. I will say that the information I'll be presenting today is as up-to-date as the current moment. That is, with an emerging infection such as Zika virus, information changes on almost a daily basis, if not a few times a day, and in some instances requires changes to public health and clinical practice. So we do our best to update our VDH website with new information as it becomes available, and I encourage everyone on the call to check back frequently with our website, but also your local health department points of contacts to make sure you have the most up-to-date information available. Zika virus is primarily spread through the bite of an infected mosquito, and I'll elaborate on a lot of the overview on this slide and future slides in the presentation today. Other modes of transmission include sexual transmission, maternal-fetal transmission, and the possibility of transmission via blood products. Clinical illness is usually mild and the symptoms last several days to a week, and I'll elaborate on the clinical course shortly. Severe disease requiring hospitalization is uncommon and fatalities are rare. Guillain-Barré syndrome has been reported in patients following suspected Zika virus infection. The exact relationship to Zika virus is unknown. It's likely triggered by Zika in a small proportion of infections, much as it is after a variety of other infections. Guillain-Barré is an uncommon sickness of the nervous system in which a person's own immune system damages the nerve cells, and it can cause muscle weakness and sometimes paralysis. And of course, the most pressing issue, I think, about Zika in general is the relationship to pregnancy. Zika is now a known cause of birth defects and other adverse pregnancy outcomes, such as miscarriage. So as I alluded to earlier, the symptoms of Zika virus in those that become ill are generally mild, and they include symptoms such as fever, a maculopapular rash, joint pain or arthralgia, and conjunctivitis. Many, or I should say most, infections are asymptomatic. Roughly what's thought to be true is about 80% of individuals that are infected with Zika virus do not become ill and wouldn't know that they've been infected. Other symptoms include things such as muscle pain and headache. And I think as more data is collected on Zika virus over time, we'll learn more about the commonality of certain clinical presentations. This table is taken from a CDC slide set, and it shows the clinical features of Zika virus disease compared with dengue virus and chikungunya virus, which are similar viruses transmitted by actually similar mosquitoes. And it's often difficult to distinguish between the three conditions. The number of plus signs in each column or cell there indicates the frequency at which symptoms were reported for each condition. In comparison to dengue and chikungunya, Zika is more likely to cause a rash and fever is common, but not invariably present. Cases are also more likely to present with conjunctivitis, cases of Zika. Arthralgia, although common, is not as prominent as it is in chikungunya, and Zika virus is not characterized with bleeding conditions such as hemorrhage or shock as it may be with dengue virus. This is just a very broad overview for some clinicians when they're trying to distinguish clinically, and obviously there's laboratory tests that can help with that decision making as well. Oh, excuse me. It's important that I reiterate that the primary mode of transmission for Zika virus is through the bite of an infected mosquito. In addition to that primary mode of transmission, there are other modes of transmission that we are learning about over time. I can recall back in February when we first started hearing about Zika virus, sexual transmission was really not discussed too much. It was a thought, but there just wasn't any evidence of it. And now, of course, we have a lot of evidence that's pointing towards that and is demonstrative of that. And now we also know, as of a few weeks ago, that the sexual transmission, although probably more likely to be transmitted from an infected man to his sexual partners, it has also been documented now that a woman can transmit it to her sexual partners. So the guidance has been updated to reflect that new knowledge. Maternal fetal transmission or transmission from a pregnant woman to her child either in utero or during delivery is a known mode of transmission. Laboratory exposure is possible, and theoretically a blood transfusion could be the source of a transmission of Zika virus if the blood were infected. So just to get into a little bit more detail about the mosquito-borne transmission, the two mosquitoes that we're mostly concerned with are Aedes mosquitoes. Aedes aegypti, or the yellow fever mosquito, is the vector of most concern. It's considered to be the most competent or the most effective mosquito vector in the transmission of Zika virus. also known to be transmitted from mosquito to person by Aedes albopictus mosquitoes or the Asian tiger mosquitoes. So those Asian tiger mosquitoes are the most common nuisance mosquito in Virginia, and they're considered to be present throughout Virginia. We do not have as much evidence of the presence of Aedes aegypti. In fact, it's been incredibly rarely documented in Virginia. So we're mostly concerned here in Virginia with albopictus, recognizing that it does play a lesser role in the transmission, but it's something we pay attention to. Both of these vectors also transmit dengue and chikungunya viruses, as I discussed earlier. Mosquitoes become infected by feeding on an infected person. Zika virus remains in a person's blood for about 1 week. We are learning more about that as time goes on, and I think the data is coming in that may push that out a little bit. With pregnant women, their blood volume and just what happens during pregnancy does often cause a pregnant woman's blood to harbor that virus longer, but it's unclear. So for now, we consider the viremic period to be that 1 week to 10-day period. In May of 2015, so over a year ago, Zika virus was reported to be circulating in Brazil, as I'm sure everyone is aware. This was the point of identified introduction of the virus into the region of the Americas. And since that time, as Dr. Ryan alluded to, Zika has spread rapidly throughout that region of the world, and obviously this has raised concern for the virus being spread to the United States through travel, which has obviously occurred. As previously mentioned, Zika virus is transmitted by mosquitoes. These maps on this slide illustrate the estimated range of these mosquito species, and the maps are generated on historical data. So that is an area that's shaded the respective color of as if the mosquito species was ever detected in that area in roughly the last 20 years. The maps do not show the exact locations or numbers of mosquitoes living in a given area, and they do not show the risk or the likelihood that these mosquitoes will spread the viruses. What they do show is CDC's best estimate of the potential range of both Aedes aegypti and Aedes albopictus in the United States. And they show areas where mosquitoes have previously been found. I wanted to expand more on the sexual transmission mode. Zika can be passed through sex from a person who has Zika virus to his or her partners, even if the infected person does not have symptoms at that time. People with sex partners who live in or traveled to an area with Zika are at risk for getting Zika through sexual contact. Studies are underway to find out how long the virus stays in semen or vaginal fluids of people who have Zika, and scientists are also studying how long can it be passed to sex partners. Later in my talk, I'll talk about what this means for clinical guidance and prevention tips. And Zika virus can be passed from a pregnant woman to her fetus during pregnancy or at the time of delivery. But this is a very simplistic infographic, probably too simplistic for the audience today, but I did want to use it because I like the image in it and just to see what's being shown to the general public about what local transmission is. What local transmission is when local mosquito populations are infected with Zika virus and then can go on to transmit it to human beings. This is what's happened in southern Florida this week. We consider the populations at risk for Zika virus as anyone living in or traveling to an area with active Zika transmission, and this includes pregnant women. People who have not traveled to an affected country or now area, such as in that neighborhood in Miami, are not currently thought to be at high risk. There is a potential that parts of the United States, obviously I made this slide before the announcement in Florida, including Virginia, have mosquitoes that could spread the virus if they bite an infected person. And the risk of local transmission of Zika is thought to be low based on historical transmission patterns of other similar viruses like dengue and chikungunya and the spread of those by the species of these mosquitoes. We have had historically reported travel-associated cases of dengue and chikungunya viruses, and that information is pretty readily available on our website, and also the ArboNET, which is the mosquito-borne illness surveillance system at CDC, where they map these cases from around the country. We've never had a locally transmitted case of dengue or chikungunya documented in Virginia. This map is as of a week ago, July 27th. These maps are updated weekly on CDC's website, so the more recent version is probably being posted as I speak. This map is generated from data through the ArboNET system, and states, including Virginia, submit our case data to ArboNET so they can generate these maps to display. In the United States, so this does not include the territories, as of July 27th, there were 1,657 travel-associated cases of Zika virus, and as of July 27th, they had reported 0 locally acquired cases. This week, they'll probably report. I'm not clear on what their exact case count is in Florida, but I imagine it will be at least 5 locally cases reported. Of those roughly 1,600 cases, 15 are thought to be sexually transmitted. That's nationwide, and 5 are thought to have had an association with Guillain-Barré syndrome, and again, that's nationwide. If you look at the U.S. territories, and this would include Puerto Rico, the numbers are flipped. Locally acquired cases reported in those U.S. territories is upwards of 4,700 cases and only 21 travel-associated cases. So they are in the throes of a locally transmitted Zika epidemic in Puerto Rico. And so the numbers are quite different for them, but the impact is quite significant. Sexually transmitted cases are not reported for areas with local mosquito transmission of Zika virus because it's really not possible to determine whether the infection occurred due to mosquito-borne or sexual transmission if both of those risk factors exist. This data is as of July 27th. These numbers are updated once a week, and it happens late Wednesday, early Thursday morning, so this number will change by tomorrow. But as of last week, almost 1,000 persons in Virginia had been approved for Zika virus testing, and of those, we have reported 50 confirmed or probable cases. Only Virginia residents are included in this table, and the cumulative number, the 50 of probable and confirmed cases in Virginia, are those that meet a surveillance case definition, which does include clinical symptoms. This slide shows the breakdown of those 999 Virginia residents who were approved for Zika virus testing as of July 27th. By region, the northern region has the majority, or 58% of residents, followed distantly by central region, eastern region, northwest, and southwest. That's to be expected because obviously the northern region is more heavily populated, so they're going to have just more people in general. So that's not unexpected for us. Among 900, not everyone, they're approved, and in a very small minority of people, they end up declining testing. So of 977 Virginia residents, only 50 or 5% were classified as those confirmed or probable cases based on laboratory and epidemiologic criteria. 775 were classified as not a case, and test results were still pending for 152 people as of last Wednesday. 22 people declined testing. I mentioned that case classification is based on laboratory and clinical criteria. Most people being tested, roughly 70%, were asymptomatic at the time, so they would not meet our surveillance case definition of a confirmed or probable case, even if they had a positive laboratory result. 88% of all those tested are female, and specifically pregnant females, which is highly driven by our testing algorithm, but that has changed a bit over time. So the numbers that are tested might shift a bit. This is the number of residents approved by Zika virus testing by health district. Not 19 health districts with less than 15 residents approved are not reflected on this slide. And again, the testing numbers, I think, are reflective mostly of population in a given district. This maps out our Zika virus testing approval by week in Virginia. On February 12th, which is marked here as MMWR week 6, CDC recommended that asymptomatic pregnant women with possible exposure to Zika virus be tested. That's marked by the arrow. You can see the number of persons approved for testing increased substantially around that time compared to previous weeks. And then in late February, or week 8, the number of persons approved for Zika testing per week peaked in Virginia, and the weekly number has remained fairly steady since then. I'm anticipating a slight increase given an expansion in our testing algorithm and the news from Florida, which tends to just simply draw more attention to the condition. And in many cases, it's a good thing because it prompts physicians and other healthcare providers to think Zika if they're presented with a patient with clinical epi criteria and clinical criteria. Excuse me. So lab testing is very complex, and it also is difficult to interpret. So I think before I go into these slides, what I'd say to any clinicians on the phone is that if you have questions about laboratory testing, whether it's to request testing approval or to request some assistance with interpreting lab results, please give us a call, give your local health department a call, and we're happy to walk through those with you because it can be confusing. The FDA has issued what's called an Emergency Use Authorization, or EUA, for several diagnostic tools for Zika virus, including a trialplex PCR assay and a Zika macrolyzer or serology testing. Our state lab conducts both of those. For appropriate patients, the PCR should be performed on serum or urine that's collected during the first 2 weeks after symptom onset. And it's recommended that if urine is collected, that's collected with a patient-matched serum specimen, so the urine and blood are submitted simultaneously. A positive PCR result on any sample confirms Zika virus infection, and no additional testing would be indicated. And this last bullet is important. A negative PCR result does not exclude Zika virus infection, and the recommendation is that serum should be analyzed by antibody or serological testing if a PCR result is a negative result on a symptomatic individual is received. PCR is available commercially. It's also available through public health testing. Regardless of where the testing is conducted, this recommendation is the same. So I think, again, for the clinical audience on the line, if you pursue PCR testing for a patient commercially, that specimen does not automatically get routed to the public health lab in most instances, so it would require some coordination with public health if you have interest in getting serological testing for a patient conducted. The Zika IgM macrolyzer test is used for a qualitative detection of IgM antibodies in serum and can also be used in CSF or cerebrospinal fluid. However, due to some cross-reaction with other flaviviruses and some possible non-specific reactivity, the results may be difficult to interpret. Consequently, any presumed positive, equivocal, or inconclusive test has to be forwarded for confirmation by PRNT, or plaque reduction neutralization testing. That testing is performed by CDC or a CDC-designated confirmatory lab to confirm whether it's a presumed or whether it's a positive, equivocal, or inconclusive result. This is a screenshot of our current public health Zika testing algorithm. This can be found on our website, and it's the current guidance for whom public health testing is available. So we encourage folks to look at this and use it to help with decision making. Public health testing does require review and approval by public health prior to specimens being tested at the state lab. Our first and foremost focus here for our Zika response is really to protect the pregnant woman and her fetus. Zika virus can spread from a pregnant woman to her fetus. It is a cause of microcephaly and other severe fetal brain defects. So that's what we know. If a pregnant woman is infected, there's unfortunately a lot we don't know. We don't know how the virus will affect that woman or her pregnancy. It's unclear how likely it is that Zika will pass to the fetus. It's unclear if the fetus is infected, whether that fetus will develop birth defects, or when in pregnancy the infection might cause the most harm or any harm to the fetus. And it's also unknown if sexual transmission of Zika virus poses a different risk of birth defects than an infection acquired by mosquitoes. CDC does advise and continues to strongly advise that pregnant women avoid travel to Zika-affected countries and also Zika-affected areas if there are more declared in the continental United States. If the travel is unavoidable to those areas, these women are strongly encouraged to protect against mosquito bites. Testing is available for pregnant women who travel to the affected area or their point of exposure was within the last 12 weeks. There are exceptions that can be made to this rule. However, a specimen that's collected outside of that window will come with a fairly strong caveat that it's unclear what the result would mean if it were negative. The validity of the testing is really within that 12 weeks, but we understand that some tests may come back positive after that window of time. If a pregnant woman has a sexual partner who traveled to an affected area, it's recommended that they abstain from sex or use barrier precautions correctly every time during sex for the duration of that pregnancy. There is no evidence that Zika affects future pregnancies if a fetus is conceived after Zika infection leaves the body. Virginia Department of Health is participating in the U.S. CDC Zika Pregnancy Registry. The purpose of that registry is to monitor outcomes in pregnant women and their infants following infection during pregnancy, and the information will be used to inform clinical guidance and public health response and to improve services for this population. How it works is that it is a supplemental surveillance effort, so it's in addition to our routine disease, reportable disease surveillance in Virginia, and it's coordinated by CDC, and CDC's registry is heavily dependent, completely dependent on the voluntary collaboration of state health departments like ours and local health departments. Pregnant women with laboratory evidence of Zika virus infection and exposed infants born to those women are the individuals that would be eligible for enrollment into the pregnancy registry. And that includes infants with lab evidence of congenital Zika virus infection. So sometimes most often we learn about a mother-baby pair via the mother being positive. There are instances in which we would learn at the first time via the infant's results. This is just a schematic of how one would determine eligibility for enrollment into the Zika Pregnancy Registry. Our local health department staff are really kind of the boots on the ground here and communicating with the healthcare providers of these women and collecting information at certain points in time during pregnancy. So VDH will coordinate with these clinicians that are providing care to these women and their infants to provide data to the national registry. The data collected through the registry will be used to update clinical recommendations. So it's important that it's collected at certain points in time. Data will be collected and shared with public health at the time of initial identification of infection, second and third trimester, at delivery, and then for an infant at 2, 6, and 12 months of age. Something I did want to mention at this point is the importance of communication between a healthcare provider of a pregnant woman, for example, an obstetrician, and a pediatrician once that baby is born. I know that that communication happens all the time on a daily basis between OBs and pediatricians for a variety of reasons. For Zika virus, it's particularly important that the birthing providers, the providers who are delivering that baby, say in a hospital setting, are aware of the mother's Zika virus status at time of delivery so that specimens can be collected on that infant at the time of birth. The specimens, it's recommended that specimens for the infant are collected within 2 days of birth. So that communication between healthcare providers is really critical, and we're continuing to encourage that communication between providers so that's a seamless process there. So CDC has begun to report this data from these 2 enhanced surveillance systems, the pregnancy registry I described and what's called ZATS, which is the equivalent registry, but it's specific to Puerto Rico. They include pregnant women with any lab evidence of Zika virus infection, regardless of whether or not the woman has symptoms. And as of July 27th, pregnant women that had any lab evidence of Zika nationwide, the number was 400. In the territories, it was 378, and that's mostly in Puerto Rico. The registries are going to be continuing to report those 2 numbers that reflect aggregated data from all of the continental United States as a whole, and separately they'll report that combined total from the U.S. territories. They are not reporting individual state or jurisdictional level information. Sexual transmission. This is evolving. The information on this is evolving. As recently as last week, some clinical guidance was issued by CDC, and I hope many of you have seen the clinician letter that was sent out from the health department earlier this week. The definition of possible sexual exposure includes unprotected sex with any person, male or female, who has traveled to or lives in an area with Zika virus. All pregnant women with sex partners who live in or travel to one of these areas, as I said earlier, should use barrier methods during sex or abstain from sex during the duration of their pregnancies. And it's recommended that providers test all pregnant women who may have been exposed to Zika virus through sex. It's also a recommendation now from CDC that during prenatal care, at every prenatal care visit, a provider asks about Zika virus potential risks or exposures. For pregnant women, newer guidance says to test pregnant women who have had possible exposure to Zika via travel or sex, and that's just a testing recommendation. The type of testing conducted will vary depending on the time of her clinical evaluation relative to her symptom onset or to her exposure. We strongly recommend that healthcare providers in Virginia that are caring for pregnant women pursue Zika virus lab testing through public health, and that's to ensure that comprehensive testing can be conducted. Although PCR is available through some commercial labs, and I believe there's one lab now that's able to do IgM testing or will be soon, the complexity of these tests and the timing of them and simply the coordination of getting results, especially if they have to be routed to CDC, happens efficiently through public health, and it's able to be much more coordinated. So at this point in time, we are recommending that if you're submitting, if you're requesting lab testing for a pregnant woman and meets our criteria, we would recommend that it come through public health. We are very busy here investigating cases of Zika, human illness cases of Zika virus in Virginia. And our epidemiology staff here works to detect these cases early, investigate those, and report any travel-associated cases up through the national surveillance system. We're always available to discuss potential needs for testing with clinicians. Our health departments are working very hard around the state, coordinating those requests and responding to them. We help facilitate testing of the clinical specimens for both diagnostic and surveillance purposes, and we coordinate getting those specimens to the lab and making sure you get the results in as timely a manner as possible. We do conduct enhanced surveillance in areas that are at risk of mosquito-borne transmission for early detection of possible local transmission. We can look at our syndromic surveillance data, which is aggregated data from emergency rooms across the state, and we can also do targeted surveillance if we have any concern at all for local transmission. There's no evidence of local transmission in Virginia at this time. And we also work collectively across the health department to ensure that education is provided to anyone possibly infected with Zika. It's really important that a person who is known to have Zika virus, especially if they're viremic while in Virginia, that they know to avoid mosquito bites, they know how to eliminate mosquito habitats in their immediate areas, and how to prevent sexual transmission of the virus to someone else. The overarching principle in controlling Zika in people who have the virus circulating in their blood is that those people avoid mosquito bites while they're viremic. And those that have Zika virus in other body fluids avoid unprotected sex while they are infectious. VHH, we have VHH staff that are responsible for recommending or implementing targeted mosquito surveillance. We have staff that can use that information to make recommendations about mosquito control, and we can also facilitate testing of mosquitoes at DCLS. And that mosquito testing data will be available on our website on Friday, and that will be updated weekly. I encourage everyone to visit our relatively newly designed VHH website, specifically the Zika virus webpage. It provides a lot of information, comprehensive, scientifically sound, and as up-to-date as we can keep it regarding prevention, testing, surveillance, and information for clinicians and patients regarding sexual transmission, tips for mosquito prevention, and pregnancy planning information according to the latest guidance from CDC. Questions, I understand, will be at the end of the presentation, so I'll stop there. I did include a couple extra slides just for reference, but I'm not going to go through those now, and the references would be available for you. Now I'm going to hand it over to Morris.
Thank you. I want to take just a couple of minutes to talk about how the association would assist you in communicating and participating in an event through its emergency preparedness program. And this would be a function of what we currently do. Keep in mind, if, for those of you that may be a bit familiar with the hospital preparedness program, that this is a largely grant-oriented program that has been part of our operations for about 12 to 13 years. And it focuses primarily on two large areas. The first is surge management, and the second is continuity of operations planning. An example, perhaps, of surge management that you would recognize would be a bus accident or a train wreck or plane crash or an active shooter event, and where the intensity of the response to the event might be increased, but the duration might be of relatively short duration. Continuity of operations planning is a bit different in the sense that it would be perhaps of a longer duration, but of less intensity during the event itself. Examples of those would be compromise to a facility's infrastructure, whether it's heating, air conditioning, or something like that, water, or increasingly we would view a cybersecurity breach as a continuity of operations concern. And there are obviously some events that would cross the border and become both surge management and continuity of operations planning, and I think a good example of that might be an evacuation of a hospital out of its building where it would certainly present a continuity of operations issue for the facility being evacuated, but would also potentially cause a surge issue for the hospital, for the facility receiving the patients. And it's in this latter rubric of continuity of operations planning that I think that this Zika efforts by us would largely take place. For those of you that are, again, not totally familiar with the program, we do divide the state of Virginia up in terms of our emergency management program into our 6 regional coalitions. And without going into a lot of detail, we can get you information on which of your facilities are included in which region, but there are 6. And initially, these were promulgated around what were the 6 level 1 trauma centers in Virginia at the time as part of their catchment areas. They're now only 5, but we have retained the 6 coalitions. And these largely correspond to the 5 public health emergency preparedness regions as well. And the way that this would function would be in 2 respects. One is that each of these coalitions do have a central governing body that meets with some degree of regularity, whether it's monthly or bi-monthly. And Zika would be routine information about Zika or Zika-related aspects would be included in those coalition meetings. But the second would be through the concept or the way that we've organized our coalitions through an entity called the Regional Healthcare Coordinating Center. And these are centers that are staffed. They're staffed 24/7. They're not always operational unless there's an event, but it is a 24-hour staffing that we do have people on call. And within that function of the Regional Healthcare Coalition, we do stress that it is not command and control. That is the function of local emergency management, but it is indeed a communications and coordination function as well. And the way that this would operate primarily would be in terms of educating clinicians about what is going on, but it would also flow the other way as well. As part of the Regional Healthcare Coalition Coordinating Centers, which we call RHCCs, we do have embedded within that a very robust situational awareness and incident coordination system. It goes by the acronym of VHHA, which stands for Virginia Hospital Alerting and Status System. And within that system, we're able to determine on a very quick basis the bed availability across the continuum of hospital operations, including a newly developed NICU application. We're able to determine which hospitals are on diversion and for what reason and for how long we're going to be diverting patients. There are other things that we can use this system to determine. That's the clinical status within the facility in terms of ICU bed utilization, availability of staffing resources. It has a patient tracking application, resource management tracking application. We're able to do alerting and notifications to the system about events that happen. And it also has a post office function which allows us to cohort different hospital personnel or personnel groups into entities that we can then do a single method of communication. So we would primarily steer the education for both clinicians and patients, and increasingly patients' family that is hospital specific. We would direct it to these types of to this organization. We also, as I mentioned, have the ability to track resources through our VHHA system, but we would also be able, again, to the same application, to be able to locate resources that are needed that are not within a particular facility and assist in the mobilization of those resources, whether it's additional supplies or whether it's equipment or those kind of things. We do in our planning, we do drills and exercises across a continuum of emergency preparedness functions a lot. We're beginning to develop some exercises and drill applications for specifically for Zika. We would also, in the sense of public messaging, be able to provide access to websites and the blogs with a very quick fashion in terms of providing information. One of the things that we do within the organization, within the association, is we do participate in a statewide Zika task force. Now, that task force includes healthcare providers, it includes the governor's office, it includes the medical society, as well as a number of medical specialties, but it also branches out into other parts as well, like blood banks and blood suppliers, the Department of Forestry, the Department of Inland Game and Fishery, Department of Environmental Quality. Look at other things like mosquito abatement and control, but Dr. Ryan and I both serve on that. And if it comes to a situation where a rapid response is needed for Zika or Zika patients, this task force has the ability to coordinate an incident command system, a unified command system that indeed we used with, I think, a high degree of effectiveness during the Ebola situation as well. And this unified command, again, the Hospital Association has a seat on that and meets with the group as needed. Additional concerns, and these are not necessarily within the rubric of emergency preparedness, but I wanted to mention them to you because we do have almost completed the development of a comprehensive statewide crisis standards of care plan. And we have noticed on the events of the past that having a viable approach to being able to identify in a crisis situation some of the availability issues or the availability of specialized equipment, specialized staffing, or specialized clinicians has been an issue. And so within our crisis standard of care planning, we're looking at things that might not directly be recognized as an emergency response, but nonetheless do create situations where additional resources are needed. And then finally, there are some things that, again, might not be totally identifiable with emergency preparedness, but do involve the association and the way we do would treat these patients, and that would be, as I mentioned, some degree of clinician availability, the availability of home health, the necessity of providing ongoing PT and occupational therapy. And then finally, there is some concern about funding, and this is a bit an unexplored area, particularly with what would happen with patients that lack insurance or otherwise care is uncompensated, particularly if they are migrated here from another country where many of the healthcare insurers that we would be familiar with are not in operation. So we're not exactly sure how uncompensated care would be taken care of for these patients, but it's something that's high on our radar screen. And then finally, vaccines. There is no vaccine for Zika at the present time. And even if there were, it's still, I think, there's a period of clinical trials that would need to go through. And we're not sure how those would be paid for as well. You may know that the current administration has made a proposal to the Congress that to fund some of these Zika initiatives, including vaccines, and the Congress did not act upon those prior to their adjournment, which they will not re-adjourn or re-meet or recongregate until after Labor Day. So we're not sure about some of the funding aspects, but I think that would be something that we would be involved with communicating to you, in part because I think it's highly likely that if funding is available through a grant process, that would be channeled to us in much the same way that the hospital preparedness program is. There are some CDC funds that have been made available to the state. I think some was announced even as recent as today. Relatively small amounts, but nonetheless valued and appreciated. That would conclude my part of the presentation. If you want that, open it up to questions.
So thank you, Dr. Forlano and Morris Reece. Right now we have a few moments left. We would like to take your questions. As stated earlier in the webinar, if you have a question, please go to the left-hand side of your control panel and hit that button will raise your hand, and we will call your name and unmute your line. So right now, either feel free to chat in your question or raise your hand. I see Ashley Getman has a raised hand. Ashley, do you still have a question? I'm going to go ahead and unmute your line. Ashley, your line is unmuted if you'd like to ask your question. Okay, we'll go to the next question. Cheryl, we see your hand is raised. I'm going to go ahead and unmute your line. Cheryl, do you still have a question for us? Okay, we're going to go ahead and move to Cindy Fisher. Cindy, I'm going to go ahead and unmute your line. Cindy, if you can unmute your line, you can ask your question. And Deborah Walsh, I'll go ahead and unmute your line if you have a question. Right now, I think that concludes it. Dr. Ryan, did you want to wrap things up?
I did, and I'm going to ask Dr. Forlano a quick question, too, for our clinicians out there. If I have a patient in my office and I want to get serological testing, do some PCR, what is the time length that it's going to take me before I can give my patient an answer on that? So if I do PCR and serological testing, how long before my patient gets word?
Mm-hmm. For the test results?
Correct.
Is that your question? Yeah. The PCR is quicker, within a couple of days, hopefully, no longer than 4 or 5 days. The serology takes longer, and I'd have to check with DCLS, but the preliminary serology, so the IgM result, can, I think, be completed within about a week, but the PRNT testing has to go to CDC, so the turnaround time on that from basically the date of specimen receipt at DCLS to a test result can be up to 3 weeks.
Okay. Thank you. Any other questions right now? Well, I thank Dr. Forlano and Mr. Reece for their information today. Our goal today has been to update you on Zika virus disease as it stands today. And as Dr. Forlano has already mentioned, this is changing daily and weekly. We will know more about the Virginia statistics by tomorrow morning, and we're hearing on a daily basis about the Florida statistics. All of this is going to be an ongoing story, and with the Olympics beginning now on Friday of this week, I'm sure there will be a storyline there too, which will talk about not just the athletics, but also the potential for Zika virus disease. And for those 500,000 travelers that are in Brazil right now, many of those are going to be returning to the United States. So keep tuned for further updates, but I thank Dr. Forlano and Mr. Reece for their information today. And thank you.
Thank you.